73% of women with recurrent urinary tract infections are getting the wrong treatment protocol, not because their doctors don't care, but because standard bladder treatments were designed around male anatomy and women's urethras work completely differently. I'm Dr. Ferghal Armstrong, and today we're exploring why your biological sex fundamentally changes how bladder conditions should be diagnosed and treated. You'll discover the precise anatomical differences that make one-size-fits-all approaches fail, why women are 8 times more likely to develop UTIs, and how understanding these differences leads to treatment success rates of 85 to 90% instead of disappointing failures. Let's start with the most obvious difference, the urethra. In women, this tube from the bladder to the outside world is just 3 to 4 centimeters long. It's a short, straight path. In men, the urethra is 18 to 20 centimeters long and takes a curved journey through the prostate gland and down the penis. Think of it like comparing a straight drinking straw to a bendy straw that's 5 times longer. Bacteria have a much easier time traveling up that short, straight female urethra. This isn't just academic, it explains why 50 to 60% of women will experience at least one UTI in their lifetime compared to less than 10% of men. But the differences run much deeper. The female bladder sits lower in the pelvis, supported by a fundamentally different pelvic floor muscle structure. Women have a wider pelvic inlet, evolutionarily designed for childbirth, but this creates different mechanical stresses on the bladder and its supporting tissues. Here's where anatomy becomes clinical reality. Stress incontinence, leaking when you cough, sneeze, or exercise, affects 10 to 39% of women, but only 1 to 5% of men. The reason isn't weak willpower or poor bladder training, it's physics. When you cough, intra-abdominal pressure spikes. In men, the long urethra and the surrounding prostate provide natural resistance. In women, the short urethra offers minimal resistance and the pelvic floor muscles must do all of the work of maintaining continence. Add hormonal changes to the equation. Estrogen affects the strength and elasticity of bladder tissues. During menopause, declining estrogen levels can weaken those support structures, making stress incontinence more likely. Men don't experience the same hormonal shifts that affect their bladder function. This is why pelvic floor physiotherapy shows a 70% success rate for stress incontinence in women, while the same exercises help only 40% of men with incontinence. Different anatomy requires different solutions. Now let's talk about what men deal with that women never do, the prostate gland. This walnut-sized organ surrounds the male urethra. As men age, the prostate commonly enlarges. Benign prostatic hyperplasia affects 25 to 80% of men over 50. When the prostate enlarges, it's like placing a clamp around a garden hose. Men develop difficulty starting urination, weak urinary streams, and frequent nighttime trips to the bathroom. This bladder outlet obstruction is extremely rare in women unless they have pelvic organ prolapse, which affects only 3 to 6% of women. This explains why alpha blockers like tamsulosin work so well for men with these symptoms. They relax the smooth muscle around the prostate and bladder neck. But prescribe the same medication to a woman with stress incontinence and you'll see what happened to my patient in the opening. No improvement and unwanted side effects. The hormonal differences between men and women create entirely different bladder environments. Estrogen receptors are found throughout the female urinary tract tissues. The bladder wall, urethra, pelvic floor muscles all respond to estrogen levels. During pregnancy, rising estrogen levels initially strengthen these tissues, but the growing uterus creates mechanical pressure on the bladder. After menopause, declining estrogen can lead to tissue thinning, reduced elasticity, and increased susceptibility to infections. This is why vaginal estrogen therapy can be transformative for postmenopausal women with recurrent urinary tract infections or bladder symptoms. One study showed a 68% reduction in the UTI recurrence with topical estrogen use. This treatment makes no physiological sense for men. They don't have estrogen receptors in their urinary tract tissues. Let's look at the numbers that demonstrate why sex-specific treatment matters. For women with stress incontinence, Mid-urethral sling surgery achieves an 85 to 90% cure rate. This procedure works by providing support underneath the female urethra, addressing the anatomical vulnerability we discussed. For men with bladder outlet obstruction due to an enlarged prostate, TURP surgery, transurethral resection of the prostate, relieves symptoms in 85 to 95% of patients. Try to perform a sling procedure on a man or a TURP on a woman and you'd achieve nothing but complications. Even conservative treatments show sex-specific success patterns. Bladder training helps both sexes equally, improvement rates of 60 to 85%. But pelvic floor exercises show that dramatic difference I mentioned, 85% improvement in women versus 40% in men for incontinence. Now let's talk about the infection risk. Remember that 3 to 4 centimeter female urethra? It's not just shorter, it opens closer to the anal opening, increasing exposure to higher bacterial load. After sexual activity, bacteria can be mechanically pushed towards the urethral opening. This anatomical reality explains postcoital UTI, which affect women almost exclusively. For men, with their longer urethra and greater distance from bacterial sources, postcoital UTIs are virtually unknown. Even the bacterial species differs by sex. E. coli causes 75 to 85% of UTIs in young women, but a smaller percentage in men who are more likely to have UTIs caused by other organisms and or experiencing complications due to underlying structural abnormalities. Current medical practice is moving towards phenotyping, categorizing patients not just by symptoms but by underlying mechanisms. For bladder dysfunction, this means considering anatomy, hormonal status, pelvic floor function, and neurological factors. New treatments are being developed with sex-specific mechanisms in mind. Tibial nerve stimulation shows 60% improvement rates for overactive bladder in both sexes, but the stimulation protocols may need adjustment based on differences in pelvic anatomy. Research on genetic markers suggests that responses to certain medications vary by sex. Personalized medicine may improve treatment success rates by 15 to 25% over current one-size-fits-all protocols. Understanding these anatomical differences isn't just academic, it's the foundation of effective treatment. Whether you're a healthcare professional or someone dealing with bladder symptoms, recognizing that male and female urinary systems are fundamentally different organs is the first step towards successful management. If you find this deep dive into urological anatomy helpful, subscribe for more evidence-based medical content. I'd love to hear from you in the comments. Have you experienced different treatment approaches based on your biological sex? What questions do you have about personalized urological care? Thanks for watching MedHeads. Remember, understanding your anatomy empowers better healthcare decisions. I'm Dr. Ferghal Armstrong. See you next time.